and death, but that's a little more difficult to study, and lots of the studies didn't address that directly. So I think NICU admission was a good proxy and something that that patients will hear and realize, like, oh, okay, that's pretty serious. I don't want my baby to end up in the NICU. And sort of, I don't know, just one of the downstream benefits or downstream effects of NICU admission is beyond the medical complications for baby, potentially just interfering with breastfeeding and bonding and all that stuff where it's important for a baby to be with mom when you can have that. So the first study, which is probably what we're going to talk about the longest, was a meta-analysis. It looked at, this wasn't the primary outcome, it looked at several outcomes for THC use during pregnancy, but what I'm most concerned about is the odds ratio of NICU admission. So the next slide has a forest plot, and this is out of 4 of the studies included in the meta-analysis address NICU admission. So that top one crosses, the confidence interval crosses 1, so it's not statistically significant. The 3 that are significant all show an increased risk of NICU admission. And then the composite data shows an increased risk of NICU admission when the mother used THC during pregnancy. And the odds ratio is 2.02. So we can say that infants are about 2 times more likely to end up in the NICU if mom used THC during pregnancy. So some other effects from that meta-analysis, we see that infants have a lower birth weight. If we look at that black arrow on the bottom, that's the composite birth weight. And on average, infants were about 100 grams less. So clinically, that might not seem like a big deal, but if we go to the next slide, we see that increases the risk of having a low birth weight infant. And that odds ratio for low birth weight is about 1.77. So we can kind of extrapolate some of the health effects that go along with having a low birth weight infant and assume there could be some health effects there. That was just some side data, but circling back to the NICU admission, we'll go through each of the 4 studies that were included just briefly. The first study came out of, can you go to the next slide, please? The University of Texas, and this is the one that was not significant. It was a smaller study, only included 183 women, but they did adjust for alcohol use and tobacco use. Specifically, this study adjusted for the number of cigarettes smoked, not just any tobacco use. So the second study was out of Australia, and this was a large sample size, N of 13,443. This did show an adjusted odds ratio of NICU admission of 2.84. And this study controlled for a lot of factors like socioeconomic factors and just medical factors for mom, as well as smoking status. They don't specifically say that they controlled for alcohol use, though. The third study is by Gagari. This is out of Iran, and I think this is a probably less representative of the population we're seeing in Tulsa, because the 7 women who did use marijuana in this study were out of a sample of about 100,000 women, and they just chose about 500 as a control. So the rate of marijuana use was only 0.006%, which is not what we're seeing in our clinic. So the other thing, if you can go to the next slide, the rates of NICU admission were very high. So even in non-users, the rates were about 30%. So I think some of this could be confounded by sort of not seeing a lot of marijuana in pregnancy, when they do see it, they might jump to just watch baby more closely. So it might not necessarily be a correlate for neonatal morbidity in that population. And then the fourth and final study that was included in this meta-analysis had an N of almost 25,000, and this was also out of Australia. This study did adjust for cigarette and alcohol smoking. And looking at the demographics, I think it's pretty adequately representative of the population that we're seeing. So this study did show a difference in NICU admission, an increase with an adjusted odds ratio of 2. It also showed a decrease in an increase in preterm birth, small for gestational age, and low birth weight infants. And I mean, the small for gestational age and low birth weight all make sense that those two should go the same direction. So some limitations from this meta-analysis are that, as with most studies on marijuana in pregnancy, it's relying on maternal self-report for the most part. And I think to get the kind of numbers, like to get 25,000 women, you can't really screen them every week for THC use, and that would be pretty cumbersome and expensive, but still we have to trust that they're being honest, which likely some people slip through. And then one of the studies didn't specifically say they excluded alcohol use, and one of them didn't really address whether they excluded tobacco and alcohol use. And then one thing I didn't talk about, but the study that had about 13,000 women out of Australia, the second study in this group, it wasn't looking at women admitted to L&D, it looked at women who had been admitted at some point during their pregnancy for THC use disorder or something like that. So that makes me think that it was a bigger problem if they had to be admitted to the hospital for it. So I think that might have skewed the results. Next slide, please. So the second study I'll talk about looked at neonates born in Ontario. Inclusion criteria were that the infants had to be at least 20 weeks gestation. And again, we're looking at the incidence of NICU admission. So one of the exclusion criteria was maternal age less than 15. Can you advance 2 slides, please? So this study showed a couple things. Did show an increased relative risk of preterm birth in the neonates of mothers who use marijuana. Also showed increase in small for gestational age and transfer to the NICU. So out of this study, the relative risk was 1.40. So again, this study relied on maternal self-report, and a problem that is common to all of these studies is that it doesn't quantify cannabis use. So someone who said, yes, I smoked earlier in pregnancy, but then I quit, versus someone who just smoked throughout their pregnancy, we don't have separate data on those populations. So before we get into the third study, here's a little bonus study to give us some background. There was a study in this was in the US actually. The Stillbirth Collaborative Research Network looked at trying to find different causes of stillbirth, and they did see an association with babies who were born stillborn having THC in the umbilical cord homogenate, which looks at drug use during the last half of pregnancy. So this adjusted odds ratio was 2.34. So that's another factor that I didn't get into much with the research, but another thing that we can kind of warn patients about. And this study didn't control well for confounding factors, so yeah, we can take that with a grain of salt. But then in 2017, a few years after the original study, they did a secondary data analysis looking at the effects of drug use on the infants who were live-born. And they were just compared with age-matched controls. And this study had a pretty good sample size and did not show, could you go forward a couple slides, please? A few. Two more. Yeah, so for this study, inclusion criteria were that the infants had to be live-born, greater than 24 weeks. The infant could not have had an anomaly, and all the data had to be complete in terms of drug use and mother's obstetrical history. Next slide, please. So the study did not show a statistically significant increase in NICU admission, and that's after adjusting for like drug use, alcohol use, lots of confounding factors. But interestingly, it did show an increased composite neonatal morbidity or death. This study broke it down more than most of the ones I saw. And so the composite neonatal morbidity or death was increased with an adjusted odds ratio of 3.11. And looking at the factors that play into that, it looks like, next slide, please. Looks like the primary thing, sorry, that's kind of small, but neonatal infection morbidity and neonatal neurologic morbidity seem to be the main things that are increasing the overall morbidity. Those both have significant p-values. Some limitations, this had a smaller sample size. I think it was about 1,600, and overall, the study population still had a lower rate of marijuana use than what we're seeing. And then something interesting is kind of like we talked about before, some people are gonna test positive who didn't admit that they used THC in pregnancy, and then there's some people who did say, yes, I've used marijuana in pregnancy, but the umbilical cord didn't show it, so that might kind of account for some of the people who do quit smoking during pregnancy. And that is all I've got. Any questions? Dr. Lukashi?
Were neurologic but also infection. So did any of these studies use GBS as a confounding factor that they accounted for in the study?
Yeah, that would be interesting to see. None of them that I looked at specifically addressed that. Angel? No, they didn't. Another interesting question, like could they have, I don't know, could people have been more likely to go to section or? Dr. Ganser? I was seeing mixed results with preterm birth. This wasn't my main focus, but it did seem like low birth weight was fairly consistent across the studies. And then the one study showing the increased risk of stillbirth. No, there are some studies that looked at like long-term effects in the children, like increased risks of ADHD and stuff like that, but I can't really speak to any specifics on that. Dr. Morgan?
This is also a little bit beyond, but in your looking for research, how far back were you finding articles? Because it seems like, you know, maybe we haven't studied this as long as we should have. That's my just thought.
most of the articles were like within the last 20 years or so. All right, well, thank you.
All right, thank you, Dr. Pierce. Next, I'd like to welcome Dr. Chris De Silva, who will be teaching us about whether or not we may use thrombocytopenia as a predictor for severe alcohol withdrawal. Come on up, Dr. De Silva.
All right, well, thank you guys for being here this morning. While Dr. Place was talking this morning, I was thinking, you know, I'm a little lightheaded, short of breath. Maybe I was a close contact, but then I remembered I have to present this morning, so I think that's it. But I will be presenting today about thrombocytopenia as a predictor of severe alcohol withdrawal syndrome. And I don't have any disclosures, no financial incentives for this research or presentation. So let's start with a clinical vignette. A 66-year-old female with a past medical history of hypertension is admitted to the hospital with community-acquired pneumonia. On day 2 of her admission, her mental status changes. It appears as though she is speaking to invisible people and itching her arms intermittently. Vital signs now show a heart rate of 105 and a blood pressure of 150/95. So, I mean, at that point, you're going to come up with a new differential. You're going to try to figure out what's going on. But on day 3 of her admission, her daughter arrives and explains that her mother has a history of alcoholism, which kind of hits at the first point of why I wanted to do this as my research topic. A lot of times when a patient gets admitted and they're an alcoholic, they're not going to admit it right off the bat. So sometimes you have to do a little bit more digging. Sometimes another person comes and gives you more pertinent history. But she comes, explains a history of alcoholism. Now that you have this additional piece of history, what other questions or lab values could you look for? And the patient's already kind of proven to you that they're not going to be forthcoming when you ask right off the bat. So a lot of the other kind of factors that play into risk for severe alcohol withdrawal syndrome are subjective factors, which have to come from history. What lab values could you really use? And that was the kind of purpose of my study. Next slide is actually just a picture of my family. It's totally unrelated, but I really wanted to show off my newborn son. He's now 4.5 months old, but that's my wife, Samantha. My son, Benjamin, is the older one, and then my younger son, Elijah. All right, so now moving on to the clinical question that I was seeking to ask. Is thrombocytopenia a predictor for severe alcohol withdrawal in patients being admitted for alcohol detoxification? So I think to kind of set the stage, we have to have some definitions for what I'm kind of address. So the first definition that I'd like to cover is thrombocytopenia. Reference range for thrombocytopenia at St. John is 150,000 to 400,000 platelets per microliter of blood. So thrombocytopenia would be defined as anything less than 150,000 platelets per microliter. The next kind of definition that I'd like to cover is what is severe alcohol withdrawal syndrome? And then there should be a graphic that kind of pops up too. Oh, wait. Maybe won't. But so withdrawal seizures and delirium tremens are most often what's grouped together to make up the definition of severe alcohol withdrawal syndrome. However, there isn't a standard definition of that. So all the research that I did look into kind of had, that was one of the limiting factors of some of the research, is that there wasn't a standard definition for what severe alcohol withdrawal syndrome was. But just to kind of dig in a little bit more, withdrawal seizures are typically generalized tonic-clonic convulsions that occur in 10 to 30% of alcohol withdrawal syndrome patients, and they occur earlier in the course of withdrawal as opposed to delirium tremens, which is a disturbance of cognition that's accompanied by kind of hypersympathetic response that occurs in 1 to 4% of alcohol withdrawal symptom patients a little bit later after they've either cut back or had complete cessation of alcohol intake. So why do we care about this? 14% of Americans have alcohol use disorder or meet criteria for alcohol use disorder, and approximately half of those will experience withdrawal symptoms at some point in their lifetime. And then 20% of patients hospitalized in the United States have an alcohol-related diagnosis during their admission, so either withdrawal or a lab abnormality that then can be tied back to alcoholism, either vitamin deficiency, low platelet count, anemia, something like that. And then also, the occurrence of severe alcohol withdrawal syndrome during a hospital stay prolongs the hospital stay by an average of 4 days. So in short, kind of like Dr. Eldog likes to tell us, it's expensive and it kills, so that's why it's important. So the first study that I used to kind of dig into this question was a systematic review and meta-analysis conducted, or the meta-analysis was conducted in 2014, but it actually looked at a variety of factors that played into severe alcohol withdrawal syndrome, not just thrombocytopenia. So it included 15 studies, but only 5 of those studies directly addressed thrombocytopenia. It didn't go deeply into inclusion criteria because all of the studies that it analyzed had different inclusion criteria, but the consistent factor was that exclusion criteria for all of the 5 studies that were analyzed were a prior history of substance abuse other than alcohol, and admission for a primary diagnosis other than alcohol withdrawal syndrome. So they had to be coming in for primary diagnosis of alcohol withdrawal syndrome. The results of that meta-analysis showed that platelet count was lower in patients with DT as compared to their no DT counterpart, and the mean difference of that was so 45 or 45,000 platelets per microliter. And the confidence interval did show that that was significant. It was also lower in patients who experienced withdrawal seizures as opposed to their no seizure counterparts. And the mean difference there was actually even greater, almost 60,000 platelets per microliter. And again, that was a significant finding. The limitation of that meta-analysis I kind of touched on in the kind of beginning when we talked about definitions, but it was just heterogeneity between what each study defined as severe alcohol withdrawal syndrome. Some focused really heavily on just DTs, some focused on withdrawal seizures, but they all kind of at least touched on both of those. Those seemed to be the 2 different categories that they would stick to. The second study that I looked into was a retrospective case control study entitled Thrombocytopenia in Patients Hospitalized for Alcohol Withdrawal Syndrome and its Associations to Clinical Complications. So that study focused specifically on thrombocytopenia, unlike the first one, which was a little bit more broad. It analyzed 150 patients, and so 75 of them, or half of them, did have severe alcohol withdrawal syndrome, and then the other half did not. The exclusion criteria in that study were current use of psychoactive substances, chronic use of drugs that would otherwise affect platelet count, or any other disease or infection that may be kind of affecting platelet count that wouldn't be related to the alcohol. And then also a previous diagnosis of neurological disorders, because that can be a confounding factor in having a seizure or hallucinations or something like that. The results of that study were that 71.3% of the patients in the SAWS group had thrombocytopenia, or like we talked about in the definition, a platelet count lower than 150,000 platelets per microliter. and only 21.3% had thrombocytopenia in the no severe alcohol withdrawal syndrome group. This study also tried to find a cutoff value below which severe alcohol withdrawal syndrome was significantly increased. That cutoff value that they found was 119,000, but the study wasn't a very large study, and it hasn't been repeated up to this point. But they were able to determine that at a platelet count lower than 119,000, there was a 95% sensitivity for severe alcohol withdrawal syndrome and a 30% specificity for severe alcohol withdrawal syndrome. The limitations we kind of talked about a little bit already, but small sample size, narrow inclusion criteria, so they kind of cut a bunch of things out with their exclusion, and then inclusion criteria, just to kind of touch on briefly, was admitted with a primary diagnosis of alcoholism, and then they had to have only, like in the inclusion criteria, they had to have only been using alcohol, no other substances or drugs of abuse. And then the study was also not blinded, so that may have affected the researchers' kind of placement of patients in the different groups. The last study that I looked into was a 2015, also a retrospective case control study called Clinical Predictors for Delirium Tremens in Patients with Alcohol Withdrawal Seizures. It had similar exclusion criteria to the previous study, but also included, on top of what was in the exclusion criteria for the second study, electrolyte imbalance on admission, hypoglycemia or hyperglycemia on admission, a history of traumatic brain injury, or ischemic or hemorrhagic CVA on admission. This study, part of the inclusion criteria was not that, they didn't require that the patients had to be admitted for a primary diagnosis of severe alcohol withdrawal syndrome. In this study, it could be a secondary diagnosis beyond the primary diagnosis. The results of this study were that patients in the DT group had a mean platelet count of almost 70,000 platelets per microliter lower than the group that did not develop DT. And then, as you can see, that was a significant finding as well. And then limitations of this study, again, small sample size and lack of blinding, being a retrospective case control study. So based on those three studies, my evidence-based answer is that a lower admission platelet count is predictive of severe alcohol withdrawal syndrome, and that strength of recommendation was an A based on a large meta-analysis as well as the two retrospective case control studies. The secondary answer that I found was that a platelet count below 119,000 is associated with higher rates of developing DTs and withdrawal seizures, but that is just a strength of recommendation C based on the one retrospective case control study. So going back to the clinical vignette, I read it before, so I won't read it to you again, but what other questions or lab values would you look for to determine the patient's risk of further deterioration? So A, history of prior withdrawal seizures, body temperature, admission CBC and Chem 14. B, history of recent trauma, 12 lead EKG and troponin level. C, history of O2 requirement at baseline or repeat chest x-ray and blood cultures. Or D, a history of recent travel, bilateral low extremity duplex ultrasound and a D dimer. So I think based on the research that I presented today, I think the correct answer would be A. You can look at admission labs and then also kind of going back through other risk factors for delirium tremens, history of prior withdrawal seizures at the top of the list for what increases your risk for further withdrawal seizures, and then body temperature would be another sign of a hypersympathetic response. Cool, and here's my sources, and then I would like to thank Dr. Matt Acker for being my FPIN advisor, and then also Dr. Ashley Hildebrand for helping review my paper and help me edit it. Cool. Yeah. So thank you for your question. The question was, if you knew that someone was coming in and they had low platelets, how would that change your management? I think if you had suspicion for alcohol abuse, even if the patient wasn't being forthcoming with it, you could put on a as needed benzodiazepine for possible withdrawals and have the nurses check CWA scores. I think this actually would benefit more in the outpatient setting. If you know that you have a patient who is an alcoholic who wants to detox, then you could get a CBC outpatient to kind of determine their risk level for needing to be admitted for severe alcohol withdrawal syndrome. Or if you have a patient who's admitted and then they kind of deteriorate a couple days into admission, like the clinical vignette patient did, then you can go back and you have something to look at that would be more objective as opposed to subjective.
The treatment of inpatient alcohol withdrawal, there's kind of this question of whether the patient needs the ICU or not. Would you prophylactically put a patient in the ICU who's undergoing withdrawal but not yet severe based on their platelet level?
So I think more research needs to be done into that. I think that the meta-analysis was able to show that platelet count being lower does increase your risk of severe alcohol withdrawal syndrome, but at this point, I don't think that there's enough research to say this is the value that we need to start calling ICU about.
The relation, like any reason why low platelets would be causing more severe alcohol withdrawals?
So that's the thing. It's kind of a chicken and the egg question. The question was, can you comment on why low platelets would be causing severe alcohol withdrawal syndrome? So I don't think that low platelets are necessarily causing severe alcohol withdrawal syndrome, but I think platelets can be used as a marker for the severity of alcohol abuse. So kind of like a vitamin deficiency could be used as a marker for severity of alcohol abuse. If a patient had a more long-term, more severe use of alcohol, platelet count should be or would be lower in that patient, and then therefore it could be used as kind of a correlative factor for worse outcomes when they try to detox off alcohol. Mm-hmm. Mm-hmm. Yes, sir. Thank you.
Find anything about carbohydrate deficient transferrin, kind of combining that with the platelet count to make your sensitivity and your specificity a little bit better?
No, sir. I didn't. All right. Well, thank you, guys.
I'm seeing a lot of phones coming out Googling carbohydrate deficient transferrin, you know. What does that mean? All right. Thank you, Dr. De Silva. Next up, I'd like to welcome Dr. Daniel Whitcomb, who will be telling us about the effect of probiotics on the incidence of gestational diabetes. Thanks, Dr. Whitcomb.
Good morning. Thank you guys for being here this morning. We're going to talk about the probiotic use in pregnant women and does it increase the risk of gestational diabetes. So kind of an outline of what we're going to go over today. We're going to start with a case. We're going to review why it's important and what gestational diabetes is. We'll look at the data, talk about our evidence-based answer, and then wrap up the case. No disclosures. So first, we have a 24-year-old female, Haveen, a baby. She's a G2, P1, 8 weeks gestational age, here for her first prenatal appointment, so she's excited. She has a history of diet-controlled gestational diabetes during her first pregnancy. Her current BMI is 22. She's lost 30 pounds since her pre-pregnancy weight on the first pregnancy after some exercising changes, diet changes. She's also changed her ginger ale habit for this pregnancy to deal with her nausea. She wants a second opinion for Dr. Google. Does probiotic supplementation decrease the risk of gestational diabetes? So what is gestational diabetes? The traditional definition is that gestational diabetes is any positive glucose tolerance test during pregnancy, although a more conventional test would be that it's in the second or third trimester, as if it's in their first trimester, then possibly it was just missed prediabetes or diabetes, not necessarily gestational diabetes. It basically is insulin intolerance during pregnancy. Why this happens isn't really clear. There's some theories that it has to do with placental hormones altering the way that of insulin resistance, but that's not really clear at this point. Who gets gestational diabetes, specifically those with a history of diabetes or prediabetes, or a history of prediabetes, not diabetes, history of obesity, advanced maternal age, Hispanic American, Native American, South or East Asian, Pacific Islander, African American, history of PCOS, or history of gestational diabetes with previous infants, or history of macrosomic infants with previous pregnancies. As far as why do we care, the prevalence kind of varies, depends on the definition that you use. If you use the Carpenter-Costin criteria with kind of the standard cutoffs of fasting glucose being 95, 1 hour being 180, 2 hour being 155, 3 hour being 140, it's about 6% of pregnant people in the US. Outside the US, it kind of varies drastically, and the studies are kind of all over the place. Some numbers are as high as 25% in Southeast Asia, or up to 33% in India, and has been increasing over recent years. Some of the reasons we care is that it does increase other negative birth outcomes, such as hypertension disorders of pregnancy, macrosomic infants, operative deliveries, birth trauma, perinatal mortality, polyhydramnios, and adverse neonatal outcomes such as respiratory and metabolic complications like hypoglycemia or hyperbilirubinemia. Long-term, it's associated with future development of type 2 diabetes, cardiovascular disease in mothers, and obesity, abnormal glucose tolerance tests, hypertension, and metabolic syndrome in those babies into their adolescence and adulthood. You go ahead. So into the data a little bit. The first and probably best study we looked at was a 2021 systematic review. Had 3 parallel group and 4 cluster randomized controlled trials, which included 1,647 subjects. The goal was to assess the effectiveness of probiotic supplementation plus pharmacologic intervention in pregnancy. Women with a history of gestational diabetes were not included, but with current gestational diabetes, they were excluded. And then each of the studies had kind of different cutoff criteria for BMIs. The intervention was probiotic supplementation. The timing of 6 of the studies was probiotic supplementation before 20 weeks of gestational age, and then one of them started at 20 weeks. Then the dosing kind of varied. It was probiotic capsules plus or minus dietary intervention, most commonly with the Lactobacillus rhamsis or Lactobacillus bifidobacterium. The outcomes measured were the rate of gestational diabetes and hypertensive disorders of pregnancy measured in the 3rd trimester. And then the outcomes obtained showed that probiotic supplementation did not decrease the risk of gestational diabetes compared with the placebo groups. It was also not associated with hypertensive disorders in pregnancy. Limitations were wide confidence intervals, broad heterogeneity between the study designs. Next is a 2013 randomized controlled trial at an N of 70. The goal was to examine the effect of probiotic daily supplementation during pregnancy on insulin resistance and serum insulin levels. The subjects were 18 to 30-year-old prima gravida Iranian females with singleton pregnancies. They were excluded if they had a history of gestational hypertension or gestational diabetes or hepatic renal disease. Both groups actually contained consumed a set amount of daily probiotic yogurt containing strep thermophiles and Lactobacillus bulgarius. But then the intervention group also consumed 2 additional strains of Lactobacillus in their yogurt. The primary outcome measured was insulin resistance, fasting glucose levels, and serum insulin levels at 9 weeks. Fasting insulin levels of the intervention group did increase less than the control group, but did not decrease. And then the insulin resistance also increased less in the intervention group, although the fasting plasma glucose and blood pressure remained unchanged. Some of the limitations of this sample were small sample size, homogeneous ethnicity. They only did supplementation for 9 weeks. Yes. It was also a single blind study rather than double blind study. Next is a 2019 case control study with an N of 249. The goal to assess probiotic yogurt consumption and the relationship with the development of gestational diabetes. These mothers were Chinese mothers at 24 to 28 weeks gestational age, single to pregnancy, no history of gestational diabetes, and they had to regularly attend clinic and have a baseline 2-hour GTT recorded. Of the groups, they were found to have similar diet and exercise habits. This trained interviewers did about a 30-minute interview with their patients, and then they did recall of their Lactobacillus acidophilus and bifidobacterium yogurt and recorded it based on low or high probiotic consumption. This was defined both in the preconception period and during the gestational period. High was recorded as greater than once a week. So most of these moms didn't consume much at all, so to have a high of only once a week. The outcome was that probiotic yogurt intake before pregnancy was not associated with the decrease in gestational diabetes compared with those not consuming yogurt. And then during pregnancy, they found that there were higher levels. Those who had the higher levels of yogurt consumption did have a significantly smaller proportion who were diagnosed with gestational diabetes compared with those in the low intake group. For probiotic yogurt intake during pregnancy before the interview, the high intake group showed a gestational risk reduction of 29.2% versus the low intake group. So kind of the weakness or limitations of this study include recall bias. Intake intervention of the group was only once a week for the high group. So the evidence-based answer, based on the strongest evidence we have, regular consumption of yogurt does not seem to alter the incidence of gestational diabetes. There are some weaker studies that do show probiotic yogurt consumption may lead to lower levels of increase of insulin resistance. And then the last study with a possible decrease in gestational diabetes, although the mechanism behind this is unclear. So gestational diabetes is a serious problem around the world, infecting anywhere from 1 in 20 to 1 in 3 women. It is associated with adverse outcomes, including gestational hypertension, birth trauma, perinatal mortality, increasing long-term maternal risk, among other things. According to the data reviewed, regular consumption of probiotic yogurt, based on the strongest evidence, does not seem to alter the incidence of gestational hypertension, despite some of the data in the older and weaker studies. So I think other options for how to decrease gestational diabetes should be pursued. How do we counsel our patients at this point? I think it's safe to say that probiotics probably don't help. Other lifestyle modifications may help, such as diet and exercise modifications, smoking cessation. There's also one area of future study, which is myostenostol. It's a naturally occurring sugar in fruits, beans, grains, and nuts. And it has been shown in some studies to improve insulin resistance, but studies specific to gestational diabetes are needed to determine its work in that. So missed the baby's past her 1 hour. She had a healthy mom, and per the IHI standard, wants to have at least 4 more children to try to get up to the 6. I wanted to take a minute to talk about Ukraine as well. I had the opportunity to go on one of the trips. I think there have been 4 so far. I think there are going to be more coming in the future, so I'd encourage you guys to pray about going and consider, especially for residents, just really a great opportunity to experience missions in this way. So here's my references. Thank you for Dr. Rylander, Dr. Hildebrand for your help with this. Any questions? That's an interesting point. Yes, thank you. Yeah, go ahead. Yeah, I mean, I didn't really see any reasons why there were benefits there, other than I just felt like the study wasn't adequate to be able to determine that. As far as just looking back and asking them to remember how much yogurt they intook, and then it's only once a week. So I'm not really sure why there was such a significant change. But sure. Sure. Especially. Absolutely. Thank you. Sure. For the first meta-analysis, it mentioned that there was not an increase in gestational hypertension. There wasn't mentioned that there may be increase in preeclampsia, so a risk of probiotics could lead to increased preeclampsia, but otherwise it wasn't really addressed. They didn't, and part of it was that it was so diverse. One of the studies, they both did the same yogurt and then just had the extra probiotic, but then some of them were probiotic capsules, some of it was probiotic yogurt, so it was just all over the place. Dr. Morgan?
So this person was really motivated to try to, eat some probiotic yogurt to like reduce your chance, right? So since we don't have an answer, how can you redirect that? Now that you know that that's not the answer, how can you like take that buzz that people are like focusing on to redirect that and counsel them? Like what kind of things do you walk away from this like thinking, right?
Yeah, so I guess I would say that overall healthy lifestyle, kind of like you were mentioning, healthy diet otherwise. Assuring your BMI is as low as you can and staying active throughout the pregnancy is kind of where I would go with that.
Yeah, I tell people, I'm like, well, we don't know that the yogurt's gonna help you, but we do know fruits and vegetables, they're like probiotics and
Sure. 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 So there could be other benefits that we didn't really address from. Sure. All right. Thank you.
All right, thank you, Dr. Whitcomb. We now have a break. I ask that you be back here at 11:15 so that we can finish up our presentations. That's about 11 minutes from now. Go get some yogurt. from these talks. Next up, I would like to introduce Dr. Timothy Choi. He is going to talk about hospital-induced delirium in elderly patients and how we may be able to prevent that. Dr. Choi.
All right. Thank you guys for coming. My name is Timothy Choi. I'm a rising third year. And I'll be talking about delirium in the hospital. And I want to thank Dr. Acker, there, the academic advisor, and Dr. Hildebrand for helping on the process. Okay, so we'll start with the case, but I'm sure everyone has seen this in the hospital. We have an elderly female who came in with multiple medical problems, and for this case, she came with an STEMI. However, during her hospital stay, she developed altered mental status. We determined that it was delirium and turned into several Burke calls and like bring over what kind of pharmacological medicine approaches that we can kind of help. About the time needing physical restraints, and just kind of, actually I'm currently on my call in a hospital, so when these things happen, I always ask myself, like, is there just something that we can kind of, help that hopefully can lower the risk of this developing, specifically, usually like the hyperactive form of delirium. So that's kind of led to my question. So delirium, why does it matter? Well, there's a lot of worse associated with worse outcomes. Generally speaking, can be a longer hospital stay, obviously, if multiple medicines needed to kind of control that, and a lot of them are like antipsychotics that can kind of overall worsen depending on what their underlying mental issues are, diagnosis-wise, and then it has been associated with increased post-discharge institutionalizations. And overall, it has been shown to increase 6-month mortality, usually after discharge too. And the discussion is whether this can be preventable, and as I'm going to talk about the studies, you can see that this is arguably that you can say it can be preventable or at least decrease in incidence. So quickly to start talking about delirium, kind of first got to define it a little bit. So generally there is a lot of scores and system that we use, specifically the multiple studies I've talked about that I will be talking about has multiple kind of scales that they use to kind of define delirium. They do all preface it by saying they're all diagnosed by like psychiatrists and psychologists and basically qualified individuals, but these are kind of the major ones that the studies will mention. Primarily, a lot of them use DSM-5 definitions. Unless otherwise indicated. And just briefly talking about delirium versus like their other terminology, including like confusional states and encephalopathy. Generally, there's like very minute details among them. Generally, it's not very like consistent differentiating them. In general, we'll call encephalopathy kind of like a diagnosis, right? But also a lot of times we also refer to that to delirium. Probably won't go too much in the pathophysiology, but there's a lot of mixed and likely multifactorial. Just kind of listing a few different things, like for cortical and subcortical, they've been shown like EEG changes and differences in EEG findings compared to someone who has delirium, have history of delirium versus people that don't. And then neurotransmitter and humoral aspect also include like acetylcholine, which we know that anticholinergic can precipitate delirium, and so there's a lot of multiple factors. And then the next slide kind of so we'll quickly talk about the DSM-5 real quick. So the primary definition of disturbance and intention usually develops over a short time, and hopefully we'll know the baseline that can help us determine that. And also, there's also additional disturbance in cognition. And another factor is we need to make sure this is not like better explained by other pre-existing diagnoses, usually neurocognitive disorder. And to understand it, it's usually caused by the current mental condition, either intoxication, like we kind of previously talked about with the alcohol, or medication side effect like anticholinergics. And on top of that, there can be other aspects of disturbances that, but the official DSM-5 diagnosis are kind of the main characteristics. So for up to date, there's a really large kind of table about possible things that can contribute to delirium. That kind of ties back to the kind of complexity of delirium. So sometimes it may be difficult to kind of figure out what's really causing it. But our point here is trying to see if there's just an additional step that we can take, generally on hopefully more on the harmless side and not potentially causing more delirium or kind of having resort to like physical restraints and such. So yeah, you can see like there's medication to drugs, an infection obviously, metabolic derangement, cognitive disorders, and kind of infection system organ failures, and other more extreme physical disorders. So the three kind of pharmacological approaches that the studies I've looked at and research they include three main ones. So these are the three ones. We'll briefly talk about them. Suvorexant, it's a orexin A and B antagonist, which the neuropeptide is believed to be really responsible for like wake cycle and wake drive. So the antagonist is believed to suppress the wake drive. It's currently approved for insomnia. Unfortunately, I don't think we have this in the hospital formulation. So, and the studies show that it's more effective at maintenance of sleep rather than inducing. And melatonin, we all know, and then melatonin is basically an agonist of melatonin. So primarily my question is if I thought about whether treating insomnia or addressing insomnia could be really helpful for preventing delirium. And I guess we kind of will go into the studies. You see that's a mixed picture, but these seem to be helpful overall, regardless of the sleep. So the first study it talks about is a meta-analysis that investigated the prevention of delirium with suvorexant. So this is a meta-analysis of 7 studies, both in ICU and non-ICU setting, and also both. And we have basically in admitted patients, they're evaluated for delirium, and all the studies have patients age over 62, except like one study, which I think the youngest was 20. And some of the risk factors, they all have some risk factor for delirium. So those include like strokes, they're hospitalized after procedures like CABG or throat surgeries, and ICU patients. And then the exclusion criteria, they are unable to take meds. They have other contraindication to suvorexant, and then they're actively delirious, or in a coma. They also limited a lot of psychiatric disorders. The psychiatric disorder kind of very broad, usually like depression or alcohol disorder and those things. And also exclude any patient actively taking psychiatric drugs, like antipsychotics and such. So the intervention they have is 15 to 20 milligrams of suvorexant at night for 3 to 7 days. I think there was one study that didn't mention the exact duration. And controls are either placebos or other sleep inducers like Zolpidem or trazodone and things like that. So the primary outcome is that the studies show the suvorexant is associated with decreased incidence by about 70%. I thought it was 30. And they also measure secondary outcome in terms of like length of hospital stay, time on ventilator, drug-related adverse events, and mortality. And the secondary outcomes, the studies do not show any additional benefits for that additional major differences. So there are several limitations. All of the 7 studies that they have looked at, specifically, they are all in Japan. So we have some limitation with the population there. And some treatment duration, they did not specify. Overall, they're pretty small sample sizes, just about 400. And then they're not very well defined, like clear age criteria. And then I think one study did not have very clearly identified randomization methods as well. And the last one of the if you remember the one of the controls, one of the study actually had mentioned in the control they actually also were given like benzodiazepine as a control. So that unfortunately will, we know that can also predispose patient to delirium. So that's one compounding factor that one study did not specifically try to account for. So the second study I have is that looked at melatonin for the prevention of postoperative delirium, and it was also an meta-analysis. It looked at 6 studies, and then the inclusion criteria are primarily post-op patients. Mean age is greater or equal to 56. And then exclusion criteria include like severe infections. I think the way to define it was if they're expected to deteriorate within the next like 48 hours, and acute intracranial events, ACS, and again, patient who were taking psychiatric meds. Intervention are either melatonin, 4 milligrams, or Remeltion. 4 of the studies had melatonin, and 2 of the studies had Remeltion, and the treatments 3 to 8 milligrams at night for up to a week, and then controls either placebo or none. So for the primary outcome, melatonin seems to be associated with a decrease in incidence of delirium by 37%, which is also statistically significant. And the limitation, again, they're pretty small sample sizes as well, and there are the smaller studies. I think one had less than like 50 patients, and some of the studies also they were insufficiently powered to detect differences. Again, narrow population. I think these were also all like all post-op, so it's limited to that population. And so they have very different kind of surgery. So the ones that are sort of actually cardiac-related, hip fractures, pulmonary resections, liver resection, and ortho surgeries. And then again, they have varying doses as well, so they weren't able to address that specifically. Just real quick, I'll share my first international trip to Egypt this past March. This is where we went to rural villages in near southern Egypt that we allowed us to provide like diabetic care. This is a patient where we were checking on a diabetic wound and then reassessing and rebandaging and provide them with supplies for bandage changes and check their sugars and all that. And we also get to pray with them, so that was great. And then the last study I have looked at was specifically looking at the effects of Remeltion and suvorexant for delirium prevention. This study has a little bit more people, and then also a perspective. This one is perspective observational study, and included criteria is again age of 65 and over, and they're either hospitalized due to acute disease or elective surgery, and then with similar risk factor for delirium like the ones I mentioned before. Exclusion criteria include they're not able to take PO, recent use antipsychotics, and actively having altered mental status, delirium, and which they also include like hyperactive and mixed kind of types of delirium as well. So not just actively the hyper type. Intervention included Remeltion 8 and suvorexant 15. And then, so I'll talk about a little bit more about the 7 plus minus 9 p.m. In a second, and control is placebo and none. So the primary outcome that they saw was, again, also associated with a decrease incident of delirium by 52% over the observed 7 days. And the way the study was designed was they have patients who take either suvorexant or Remeltion at 7 p.m. And then if they don't feel sleepy, and at 9 p.m., it was up to their discretion to take an additional dose of either suvorexant or Remeltion. And then they also look secondary outcome was they also looked at recurrence of delirium, also decreased in patient who also received this kind of treatment. And this study was different because they also looked at sleep quality as well compared to the other two studies I looked at, which there's a very specific grading system that they use. I think it's the Japanese, I think. But the scoring system also is, pointed to a improvement of sleep quality as well in the patients who also have decreased incidence of delirium. So limitations, medication, again, especially the second dose, they were taken at the discretion. And then, again, it's a subjective evaluation of sleep quality with the questionnaire. And they also mentioned that the fact that delirium can sometimes be recurrent and can rather a waxing waning nature of that and rather not recurrent. So which they're since that we are still, it's a complex topic and condition, so we don't know. So that's one of the limitations as well. So with the data that we looked at today, I think the question of whether we may have prevented delirium, I think there's a good chance that we can. I think it's given that it's consistently showing that there's a decrease, and also the fact that it's a generally really tolerated approach to treating insomnia, and then hopefully it helps insomnia. But if melatonin is pretty well tolerated medicine, as well as Melatonin. So I would say with the last set of third study, I would say there is a decreased incidence of delirium and hospitalized elderly patient, and it's up to by 52% compared to placebos. And I was able to calculate the number to treat, which is about 12 patients. And that's my references.
Maybe I missed it. Did you have dosage for the melatonin they used?
For
Whether it was time release or
which study?
any of
They did not specify if there's they just specified it was from just Melatonin. They didn't say it was like any kind of extender or short acting.
I think I heard in the first study that it decreased the delirium, but didn't have any benefit for secondary outcomes.
Yep.
I don't think I heard the follow-up on secondary outcomes, length of hospital stay, morbidity, mortality in studies 2 and 3.
Yeah, they did not look at the other two studies did not address those, did not measure those parameters as secondary outcomes. They primarily looked at just the incidence of delirium.
Yeah, to me, those secondary outcomes
Right.
are critical.
Also very correct. I agree. Yes. It's just that they fortunately did not really address that specifically. Angel. Right. So the studies, they all exclude those patients, and we know that patients who have delirium and say Parkinson's disease, they have a much higher risk factor. Those are risk factors for delirium as well. So what they're trying to do is see if when we have like even those compounding factors, but also other reasons why they're primarily in the hospital, but they are still at risk of delirium. Are these regimens able to at least decrease the incidence? Yes.
Could you go into a little more detail on your CalCall numbers needed to treat? And you're saying that you have to treat 12 to prevent remission?
Yeah. So I think the number I used, it was with the. If I recall, it was with these numbers specifically, because yeah, I had a calculation somewhere in my notes. Hold on. was with the yeah, it was with the set of numbers here with the last question there. Hold on, there we go. Yeah, with this 15.7 and 24%. This was with when they combined the primary outcome and the secondary outcome in terms of also preventing recurrence of incident of delirium. Because when they looked at the recurrence, they also, when they included patients who are not actively having delirium, they also did include patients who has had delirium in the past. So they're trying to count, they're categorize those patients as if they develop delirium again as a recurrence. So they included those patients, the recurrent part, and then a primary onset of delirium. And those are we combine the data for that. That's the percentages. Yes.
You probably have mentioned it and I missed it, but
Mhm.
can you just put for us into context?
Mhm.
What was the idea behind using a sleep medication to
Mhm.
prevent delirium in this population?
Mhm.
And if there's a mechanistic,
Right.
you know,
Right. So my original question was wondering to see if it's treating insomnia specific, addressing sleep quality would help. But what most of the studies for the first two studies did not really address the sleep component. But even without addressing the sleep component, with these medicine, they are seeing decrease in incident of delirium. So they mentioned a few things about thoughts about behind why they are seeing that, and basically they're saying we're not not entirely clear about the mechanism because they measure specifically sleep. So the idea that sleep was helpful, we couldn't say that specifically. They think about whether it's more of the wake cycle and the mechanism behind like the neurotransmitters, the neuropeptide related changes from those medicines, whether those are the ones the pathophysiologic actually responsible for the improvement, but they're unable to measure that. Yeah.
Thank you, Dr. Choi. To finish up our scientific assembly for this year, we have Dr. Sean Wilson, who will be telling us about whether the use of continuous glucose monitoring can help reduce the incidence of hypoglycemia and hospitalized type 2 diabetics. All right, Dr. Wilson.
All right. Well, thank you, everybody, and thank you, Dr. Hildebrand. Yeah, I'll be talking about continuous glucose monitoring in hospitalized patients with an emphasis on hypoglycemia.
And as you talk, let's raise the microphone and put it closer to your...
Is this better?
That's much better.
Okay,
Thank you.
thank you. Let's get started. And just to give you some background, I'd like to start with a clinical case, okay? So in the back of your head during this talk, if you have this in the back of your head, Peggy Sue, a 67-year-old female who was admitted for pneumonia, has history of type 2 diabetes, and when she takes 30 units of long-acting insulin twice a day and 8 units short-acting at meals. She reports having dizzy spells at home, and notes on previous admissions she has frequently been hypoglycemic. She uses Dexcom G6. And so a question on admission, would you consider using the patient's continuous glucose monitor during her hospitalization? And just to give some background of why I chose this topic, intern year, I finally got a patient on a continuous glucose monitor, and who happened to be an engineer who would bring me all his reports. His 3-week summaries, his 6-week summaries, his one daily report. And I thought it was very interesting that you have all this data for someone in an outpatient setting, but someone who is in an inpatient setting, and which with more acuity, you don't see all those factors. You usually get a fasting mealtime sugars. If you're a mean doctor, you get a 3 a.m. sugar. Besides that, that's all you have. So I was curious about that clinical utility and seeing like the velocity or rate of change applied to the inpatient setting. And to juxtapose that patient to some readings of a person who's been on our inpatient service before. This is from a middle-aged female who's been at our service 4 or 5 times. Comes in with these lower extremity cellulitis, lower extremity infections, brittle diabetic who easily becomes hypoglycemic. When I was an intern, we had the glycemic care team on board, and we'd have to talk with them. And I remember talking with one, I believe her name was Dr. Peggy Krissa, and going over some of her readings overnight. She was like, I'd be curious to see what it would show on a continuous glucose monitor. And with that, I developed that clinical question. Does continuous glucose monitoring in type 2 diabetics lead to less hypoglycemic events while hospitalized? And just a funny slide, I feel like I could relate to the guy on the right sometimes. Make sure we educate our patients on what rotating injection sites actually means. All right, let's get started with our first case. So Singh et al. Was a randomized controlled trial done in 2020, which looked at real-time continuous glucose monitoring if it could prevent hypoglycemia in non-critical care patients in a population of type 2 diabetics on insulin. They used a Dexcom G6 as their intervention, and they compared it to point-of-care capillary blood glucose measurements. The outcomes they're looking at were hypoglycemic events per patient and percentage of time spent in hypoglycemic range. Study design, they looked at 72 patients, 36 patients in the treatment group and 36 in the control group. Inclusion criteria was omitted type 2 diabetics on insulin outpatient, and looking with one or more risk factors for hypoglycemia. The patients were expected to have a stay greater than 72 hours, and they used the Dexcom G6 as an intervention. And they created what they called this glucose telemetry system, where they had an iPhone in the patient's room and an iPad at the nurse's station, where they were able to see real-time continuous glucose data. There were alerts set for blood sugars less than 85, and high glucose alerts set for sugars over 400. The controlled group had a Dexcom G6 without alerts, without the iPad, without the whole system, just to compare time and range. And then the exclusion criteria was less than 72 hours, patients not on insulin regimens, outpatient, pregnant patients, patients admitted to ICU, and patients requiring an insulin drip. And the main measurable outcomes was hypoglycemic events less than 70, clinically significant ones less than 54, time and range less than 70, and significant hypoglycemic events less than 54. They used an unpaired student t-test if normally distributed, and a Poisson regression test if not. And the time spent in severe hypoglycemic range was the only one that was not normally distributed. So here are the results, and let's start with the graph. Here it is. Here on the y-axis, we're looking at the number of events per patient, okay? And we have it coupled based off their blood sugar rate, hypoglycemic event less than 70 and hypoglycemic event less than 54. So the treatment group is the black and the control group is the white. So for hypoglycemic events less than 70, there was on average 0.67 hypoglycemic events per patient in the treatment group, compared to 1.69 hypoglycemic events in the control group. And this was found to have the treatment group to have 60% fewer hypoglycemic events with a p-value of 0.024. And then just let me clarify real quick. I don't want to create some confusion with these confidence intervals. These are not statistically powered confidence intervals based off an odds ratio or a relative risk ratio. A better way to put it would be a descriptive analysis of the data. So this was the range of events for the treatment group and the range of events for the control group. For severe hypoglycemic events, there was 0.08 events in the treatment group on average per patient, and 0.75 events on average in the control group. And so there's fewer severe hypoglycemic events seen, and then the numbers needed to treat were calculated. Number needed to treat 10 for hypoglycemic events and 15 for severe hypoglycemic events. And then continuing on for our results of percent of time in range, or below range, on the graph, this is looking at the percent of time in a hypoglycemic range for the treatment and control group. So for the treatment group, 0.4% of time in an average day, they were in a hypoglycemic range, meaning 99.6% of time they were in a euglycemic or hyperglycemic range, compared to the control group being 1.88% time in a hypoglycemic range. So this showed decreased percent of time in hypoglycemia with a p-value of 0.002, and then the descriptive analysis as follows with the two ranges. In essence, the control group had 21.3 minutes more in a hypoglycemic range in a day compared to the treatment group. And then the number needed to treat calculated was 24. And then looking at severe time in hypoglycemia in a severe range, the treatment group had 0.5% time in a day on average in a severe hypoglycemic range compared to 0.82% in the control group. With the descriptive analysis, those are the ranges between the treatment and control group. And the number needed to treat calculated was 47. And to put it in perspective, for the control group, on average, there's 11.1 minutes more in the in a severe hypoglycemic range. So, what was Singh et al.'s conclusions? Real-time continuous glucose monitoring can decrease hypoglycemic events in a hypoglycemic state compared with standard of care, point of care capillary blood glucose measurements. Limitations: this is a very small study, N of 72. Evidence LC, low quality with disease-oriented outcomes, and there was significant exclusive data. So just to give a quick life update, this past year I became an uncle, and this is baby boy Aiden, and it's been so much fun being a crazy cool uncle to him. I go back to Arkansas very frequently. And let's go to our last study. We have Fortman et al., a randomized control trial done in 2020 with the objective of can real-time continuous glucose monitoring improve glucose management in the hospital setting. So they had a broader objective than the first study. They weren't just looking at hypoglycemia, they were looking at euglycemia and hyperglycemia as well. Similarly, the same population, type 2 diabetics. The intervention was with the Dexcom G6, and they were comparing the real-time continuous glucose monitoring, again, to point-of-care capillary blood glucose, and they were looking at improved glycemic control in the hospital setting. So the study design, they looked at 110 patients, 53 in the control group and 57 in the treatment group. Their inclusion criteria was adults with type 2 diabetes who had blood sugar over 200 with 3 values and requiring insulin. That was their inclusion criteria. Their exclusion criteria, similar to the last study, patients admitted to the ICU, patients requiring an insulin drip, as well as patients with an adhesive allergy, and then patients anticipating a CT, MRI, diathermy. They had a similar system last time with real-time monitoring with an iPhone, an iPad at the nurse's station, and then with notifications for hyperglycemia and hypoglycemia. And the outcomes they were looking at were percent of time in hyperglycemic, euglycemic, and hypoglycemic range, as well as a mean glucose for this. So these were the results. So let's start here at the top. The TIR is the time in range, and they had 3 definitions for that. A very loose definition of time in a good range. Euglycemia would be 70 to 250. This is the treatment group. the percent in range versus the control group with the descriptive analysis of their range, and then our p-values. So the treatment group for a range of 70 to 250 was statistically significant. More patients with continuous glucose monitor was more in range for this definition, as well as the 70 to 200. However, when you look at, in my opinion, a better definition of euglycemia from 70 to 180, it is not statistically significant. However, looking at hyperglycemia, the treatment group had a fewer percent in a hyperglycemic range in this study. Hyperglycemia defined as over 300 and 250, and this was found to be statistically significant. Looking at my study, or my clinical question was really hypoglycemia, and unfortunately, they were not really in a hypoglycemic range for the most part, and there were very few hypoglycemic events. And so there was no difference based on those results for hypoglycemia. So what was Fortman et al.'s, lastly, the mean glucose for the study, the mean glucose in the treatment group was 212, and it was 191, and in the control group was 212 with a significant p-value of 0.0115. So the conclusions of Fortman et al., real-time continuous glucose monitoring can be implemented in the non-ICU hospital setting to improve glucose management. But for my specific clinical question, I didn't see it in hypoglycemia, more for hyperglycemia. Limitations: this was a small study, strength of evidence C with disease-oriented outcomes. And it had, I would say for my study for hypoglycemia, non-specific inclusive data. I don't know the A1Cs of these diabetics. I don't know what type of insulin they were on outpatient, or if they even were on. So their risk factors for hypoglycemia are kind of unfounded. And this gets me to my HDA. My help desk answer: does continuous glucose monitoring in type 2 diabetes lead to less hypoglycemic events while hospitalized? And I would like to really say yes. However, with the studies being low-powered, I would say perhaps, potentially. Hospitalized patients with type 2 diabetes who are monitored with continuous glucose monitoring seems to experience fewer numbers of hypoglycemic events and less time in a hypoglycemic state compared with patients monitored with point-of-care capillary blood glucose measurements. In essence, we need some larger studies. And what is the American Diabetes Association's stance on this? Lacking controlled trials, their stance is insufficient evidence to recommend widespread use of continuous glucose monitoring for hospitalized patients. However, in 2020, with COVID, the FDA allowed emergency use authorization to use continuous glucose monitoring in the inpatient setting, in which there are some interesting studies going on now. One is Spinakis et al., which currently unpublished, but planning to be published in the American Diabetes Association Journal later this year. So it'll be interesting to see from that emergency use authorization what comes in the next 1 to 2 years, really. And so back to our clinical case with our patient. I would say a best answer would be to allow the patient to continue to wear their continuous glucose monitor and use their own device as adjunctive use to standard of care, point of care testing. It is best if hospital protocols are in place for home CGM use. And when I spoke for the residents with Ascension St. John Hospital supervisor this past week, he didn't know of any hospital protocols in use. I'd like to thank Dr. Chris Jenkins so much for this endeavor, Dr. Hildebrand as well, while Dr. Jenkins was out with a surgery, for your help with this endeavor, and the FPIN editorial team, Ms. Janet and others. Here are my citations and resources, and thank you. I'll take any questions at this time. Yeah, continuous glucose monitors are expensive. So yeah, that's I went to a hospitals conference in Nashville, and that's the big question. It's expensive compared to what we have now.
Something I wasn't clear about was how many studies was every patient put on a CGM?
Yes, yes. But only one had like a nursing protocol reporting, an iPad up. That's how they were able to compare the time and range between the two. Dr. Place?
None of these were manufacturer sponsored or involved. I just noticed Dexcom was the only CGM. Any idea about the Libre or any other studies that other?
Yeah, so looking at the Libre, the only studies I could find was just comparison to POC to make sure they're accurate, not decreasing hypoglycemic events. Dr. Lukashu?
So obviously, to kind of set up a glucose telemetry takes a lot of systemic changes. But what do you think are the barriers to a hospital such as St. John allowing the use of continuous glucose monitoring and reading from a patient's monitor that they already have, instead of having to use a POC glucose and another stick on that patient?
Yeah.
What do you think are the barriers and how do you think they can be overcome?
I think the biggest barrier would be nursing education, especially with a lot of the new nurses we have at St. John, and how to use it. There, I would suspect the best way to use it is have the patient do it with their iPhone or their reporting system, and a communication with their nurse on a frequent check-in, an hour, 2 hour. Type of situation. But the biggest barrier I would say would be the nursing personnel and education. Dr. Crouch?
Considered standard of care where the insurance companies pay for that additional cost in the hospital?
Not at this time. I doubt it. Dr. Jones?
There's a lot of data showing that hyperglycemia leads to worse outcomes and things like wound healing, trauma, verification. Do you think that, and I think a lot of times the kind of catch-22 is they attempt to maintain euglycemic control, but the risk of hypoglycemia is kind of the limiting factor there. Do you think in these situations, like post-surgical patients or critically ill patients, this would be a method that could be extended to their care and kind of help lessen those hypoglycemic events and tighten up their glucose control, maybe lead to better outcomes?
Yeah, these studies in general are in the non-ICU setting. There's been studies done in Austria. There's a big one done, and it was more looking on using a very slow continuous insulin drip to create a homeostasis, a closed-loop system with a continuous glucose monitor. Yeah, I think it'd be beneficial. Yes. Okay. Gotcha.
There's a lot of nuances about these, so there's interstitial. So when you have obese people, once you put them on, sometimes they're not diagnosed with that consequence.
It was brought up, but there was no adjustments that I saw. Another was with Tylenol too, being that can change it. But with the Dexcom G6, the Tylenol issue was over. But for obese patients, I didn't see any on that part. Yes, sir.
Just clarification, is the system expensive? Is it the equipment or is it the personnel time that have to manage it?
I believe both. With the personnel, in the first study, it showed there was 15 interventions done with nursing, either hyper or hypoglycemic done, compared to the treatment group, there was 80 interventions. So, I mean, that's 80 or 65 more times someone is laying eyes on a patient, which also could be a confounding difference.
Hello, everyone. Congratulations to all the FPIN presenters for being done. Can we give one more round of applause? All right. Just a few quick announcements before lunch. We're going to be starting lunch at 12, and we have free time essentially until 5 p.m., which is dinner, and then the ceremonies start at 6. During free time, feel free to check out some of the apparel that's being sold in the main lobby, and there will be games inside, and I think some people are playing basketball outside. Don't forget to hand in the CME form before you leave in that basket. Don't give it to Kristen. Put it in the basket. Make sure you complete it before you leave to get credit, and also make sure you sign in for your attendance so that we can just keep track of everyone who's been here. All right, let me close this in prayer for lunch. Father God, Lord, we are so grateful for the opportunity to not just fellowship, but also to learn, Lord. Thank you for striving to push us to be more excellent in our care. I pray, Father, for us to all remember some of the things we've learned through these FPIN presentations. May it help us to be better doctors and to continue to just share your gospel in a more effective way, Lord, and through our medicine. God, I pray for just good fellowship, edifying fellowship, Lord, and may you bless this food and just nourish it for our bodies. In Jesus' name, amen.